Okay, so is everyone back? All right, so I have on the screen just an example of angiocath sizes. So as you can see, we talked about the 18 gauge and the 16 gauge. You can see that the 14 gauge is kind of ginormous. We tend to only use the 14 gauge for really viscous infusions, but 16, 18 gauges, you'll see those very commonly used in adult care. You might need a 20 gauge if you have a very thin, it might be an adult who's very thin. So you might use a 20 gauge. We certainly use 20, 22s, and 24 gauge angiocaths in pediatrics. So I just wanted you to have an example of what the bores look like, what the diameters of the catheters look like, what the lengths of the catheters look like. Okay. So I know Fred had asked about transverse positioning. So I just wanted to show this slide to give you an example of what a transverse positioning would look like. Remember, I said it's right, the presenting part is right at the side, not anterior, not posterior, but at the side.
So my question on this one was, if you present this on the test, like, will we get it in this fashion? Because it's kind of hard to tell it's transverse by the one on the right.
Yeah, it will be clear.
Okay.
It will be clear if I have no idea what's on the exam, but should I do that? Yeah, I know that transverse can be very, looking at the one on the right, it would be difficult to tell. So yeah, I will make it clear.
Thank you.
So here is a posterior. So just a reminder that we're always looking at the presenting part.
Professor, for the position, if the baby is a occiput posterior, is possible, right? So with this part on the coccyx.
Yes, and we'll talk about that in complications.
Later, okay.
Yes. Okay. Okay, intrapartum fetal monitoring. So a couple of things, reminders, fetal oxygenation. So as I mentioned, contractions interfere with blood flow into the placenta. We've already talked about fetal compensatory mechanisms, things that the oxygen reserves for the 1 or 2 minutes during contractions. I've already talked about that. And just reminders about fetal circulation. The umbilical vein carries oxygenated blood, umbilical arteries carry deoxygenated blood. So for the this entire system of fetal oxygenation to work, it requires adequate blood flow on the maternal end as well as on the fetal end. It requires adequate oxygenation. You need a functioning placenta, a functioning umbilical cord. So just keep the pieces of the puzzle in mind. Last week when we spoke about tests, I think specifically when we talked about NSTs, when we talked about kick counts, I mentioned that the role that the central nervous system plays in the fetal heart rate, in regulation of the fetal heart rate. So again, we need balance with all of these mechanisms to regulate the fetal heart rate, to keep cardiac output at a sufficient rate, at a sufficient level, for the fetal brain to remain oxygenated. So these are the components of the central nervous system that factor into fetal heart rate regulation. Now, I don't know offhand if your A&P course went into them. I'm not going to, at this point, I'm not going to require you to know exactly the role that each of these plays in regulation of the fetal heart rate, but I do expect you to remember that the central nervous system plays a significant role in regulation of the fetal heart rate. Okay. All right. Now, maternal cardiopulmonary, pathological influences, things that can impact fetal oxygenation. So maternal cardiopulmonary alterations. If the blood flow is altered within the mother, so if she has a cardiopulmonary condition such as hypertension. Hypertension reduces placental perfusion. So that will impact fetal oxygenation. That can cause maternal hypertension, can cause vasoconstriction of the placenta. That will lead to a reduced rate of fetal oxygenation. If the mom is prolonged in a position of supine hypotension, less oxygen to her means less oxygen to the fetus. Anything that impairs perfusion to the placenta impairs fetal oxygenation. So uterine activity, bringing us back to labor and delivery. Remember that when the uterus contracts, not only is the blood flow to the uteroplacental unit diminished, but the muscle itself contracts. So that further impairs placental perfusion. So again, I've said it before, but contractions that are too long, too frequent, and we're going to talk about numbers in a minute, but for right now, contractions that are too long, too frequent, if there isn't a sufficient resting interval for the uteroplacental unit to reperfuse, that is going to impact fetal oxygenation. Placental disruptions. Last semester, I'm sure you talked about myocardial infarctions. So the same process, the same kind of thing can happen with the placenta. So if you have a placental infarct, if the placenta pulls away from the uterine wall, if it what we call a placental abruption, anything like that can alter fetal oxygenation. If there is an interruption in umbilical blood flow, the umbilical cord becomes compressed. The umbilical cord has a tight knot. We spoke about nuchal cord multiple times, especially if it's very tight. What else? Knots in the cord, if the cord is compressed, if there is insufficient amniotic fluid to cushion the cord. So if the patient has oligohydramnios, that can impact the blood flow, because remember the cord and the fetus should have this buoyancy and there should be cushioning. Fetal alterations, if the fetus has an alteration in the central nervous system, a congenital defect in the central nervous system that impacts the fetal heart, that is going to impact oxygenation. So you have to remember also that there can be defects in the fetus that impacts oxygenation to the fetus. Central nervous system abnormalities, cardiac abnormalities. If this fetus is going through severe bradycardia, if there is persistent tachycardia in the fetus, any of those can result in diminished fetal oxygenation. So any potential risk factors, again, I'm going to take you back to the history. You should have, when you looked at the maternal history and you saw that she was diabetic, she's hypertensive, she was in a motor vehicle accident. These things should start to occur to you. There can be an impact, a negative impact on fetal oxygenation, okay? So, intrapartum monitoring, why are we even bothering to do this? Our purpose is to determine fetal status and to identify any fetal hypoxic stress. Okay, so not Wharton's jelly. So Wharton's jelly, if there's a diminished amount of Wharton's jelly, that signifies something else, not this. Okay.
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 Thank you.
Yeah. All right. All right. So,
Professor?
yes.
So you mentioned about the
Hydramnios. That's going to be a spelling word on the exam.
Yes.
Okay.
So you only mentioned about the oligo, but what about the too much
There's
amniotic?
so remember what I was saying was what can impact the umbilical cord. Didn't he? Okay. What I was saying is what can impact the umbilical cord. So you need sufficient fluid to cushion the umbilical cord. So if you have extra, that's not going to be that's not going to create this problem.
Okay. So only
okay, because if you have it's more if you have oligo. Okay.
Thank you.
Okay. All right. So we need sufficient oxygenation. So there may be a decrease. The potential reasons for diminished oxygenation may be on the maternal end. So maternal diminished blood flow through the maternal vessels. There may be that the mom may not be taking in sufficient oxygen. There can be alterations in fetal circulation, or there can be something that is actually wrong with the placenta. So basically what I just said. All right. Now, doing this monitoring, how are we going to do it? There is manual and then there's electronic. I'm going to speak about manual like very little, minimal, because we do most of our monitoring electronically. So if we are doing this manually, we are using auscultation and palpation, auscultation and palpation. So we would have to use a fetoscope to listen to the fetal heart rate. And then we would have to palpate the contractions to determine the intensity. So when you're doing this, if you're doing this manually, you are feeling, again, through the abdominal wall to assess the uterine tone. Okay, through the abdominal wall to assess the uterine tone using your fingertips. If what you're feeling, if it's easily dented, if you can press in and it's easily dented, those are considered mild contractions. And so that would feel actually like you're pressing on your chin. Okay, that's what it feels like. If it's slightly difficult to indent and it feels more like your nose, those are considered moderate contractions. Strong contractions, you cannot indent, so it feels very firm and that feels like your forehead. So just as a point of reference, that's what it's feeling like to your fingertips, okay? Now, you would have to go in and keep doing this, right? So in terms of your nursing care, it's time and labor intensive. So those are some of the limitations of it. It's time and labor intensive for you. It does not give you an ongoing reading of what's going on for every contraction. So you only know what's happening when you assess. So if this fetus is in trouble, you don't really know it until you go in and assess, all right? And by then, it may be too late. On the other hand, the advantages are that the mom can get up, she can walk around, she's not tethered to anything, she's not connected to a machine. If you are lucky enough to work someplace that has a whirlpool, she can just go in the whirlpool. You know, there's much more freedom of movement. It provides for a more natural atmosphere, less tech, so to speak, okay? But again, it doesn't give you the level of information that electronic monitoring will give you, okay? All right. So I'm going to try this again. I'm going to stop sharing for 1 second and try again. My video was not working just a minute, so just bear with me. Let's see what number it was. Again. I just get it. Okay, so fingers crossed. If I get it to play, I'll play it twice. All right, here we go. Awesome. Awesome, awesome, awesome. Let's see.
To perform Leopold's maneuvers, wash your hands, position the woman properly, and stand at her right side facing her. Or if you're left-handed, stand at the left side, which may be...
Audio's no good.
I know.
Just making sure.
I'm just making sure that it would play before I can share the sound. Okay. There we go. All right. Please play. Let's see if I can raise All right, let's try it again.
To perform Leopold's maneuvers, wash your hands, position the woman properly, and stand at her right side facing her. Or if you're left-handed, stand at her left side. Perform the first Leopold's maneuver to identify the fetal lie, which may be longitudinal or transverse, and fetal presentation, which may be cephalic or vertex, or may be breech. To do this, lightly palpate the woman's upper abdomen and identify the fetal part in the fundus. If the part feels relatively soft and irregular, you're palpating the buttocks. If the part feels round, firm, freely movable, and ballotable, you're palpating the fetal head. If you feel the head or buttocks in the fundus, the lie is longitudinal. Otherwise, the lie is transverse. Next, perform the second maneuver to further identify fetal presentation. Using the palm of one hand, locate the fetal back by its smooth convex contour. With the opposite palm, feel for the irregularities that are the feet, hands, and other small parts. Now carry out the third maneuver to determine the presenting part, which is the part of the fetus over the pelvic inlet. With your dominant hand, gently grasp the lower pole of the uterus between the thumb and fingers and press in slightly. While facing the woman's feet, perform the fourth maneuver to assess the descent of the presenting part. With the palmar surface of your fingertips, outline the presenting part, which is usually the fetal head. If the presenting part has descended deeply, you may be able to outline only a small portion of it. If the head is presenting and isn't engaged, identify its attitude by palpating the cephalic prominence, which is the side with greater resistance. If the cephalic prominence is felt on the same side as the small parts, the head is flexed and the vertex is presenting. If the prominence is on the same side as the back, the head is extended and the face is presenting. After completing Leopold's maneuvers, help the woman into a position of comfort and discuss your findings.
Professor, you are muted.
Any questions? I'm going to show it again because I know the first time it's like, what was that? But any questions offhand? Okay.
To perform Leopold's maneuvers, wash your hands, position the woman properly, and stand at her right side facing her. Or if you're left-handed, stand at her left side. Perform the first Leopold's maneuver to identify the fetal lie, which may be longitudinal or transverse, and fetal presentation, which may be cephalic or vertex, or may be breech. To do this, lightly palpate the woman's upper abdomen and identify the fetal part in the fundus. If the part feels relatively soft and irregular, you're palpating the buttocks. If the part feels round, firm, freely movable, and ballotable, you're palpating the fetal head. If you feel the head or buttocks in the fundus, the lie is longitudinal. Otherwise, the lie is transverse. Next, perform the second maneuver to further identify fetal presentation. Using the palm of one hand, locate the fetal back by its smooth convex contour. With the opposite palm, feel for the irregularities that are the feet, hands, and other small parts. Now carry out the third maneuver to determine the presenting part, which is the part of the fetus over the pelvic inlet. With your dominant hand, gently grasp the lower pole of the uterus between the thumb and fingers and press in slightly. While facing the woman's feet, perform the fourth maneuver to assess the descent of the presenting part. With the palmar surface of your fingertips, outline the presenting part, which is usually the fetal head. If the presenting part has descended deeply, you may be able to outline only a small portion of it. If the head is presenting and isn't engaged, identify its attitude by palpating the cephalic prominence, which is the side with greater resistance. If the cephalic prominence is felt on the same side as the small parts, the head is flexed and the vertex is presenting. If the prominence is on the same side as the back, the head is extended and the face is presenting. After completing Leopold's maneuvers, help the woman into a position of comfort and discuss your findings.
Professor, you are muted.
Questions?
I wrote the Leopold maneuver are done in the third semester when the baby is big enough, right?
So Leopold, I'll speak about why it's done in just a minute, but I want to know if there are questions about how it's done.
I think it's more difficult than what it looks because
Yeah.
when I was pregnant, I would try to feel it and I couldn't find anything.
So if you're trying to do it on yourself, it's also going to be difficult because of your position, right? But basically there are four maneuvers, and each one your goal is a little bit different. For our purposes, I'm going to limit this to, you are doing this to determine the position of the fetus. And you also need to know the position of the fetus so then that you will know where to assess the fetal heart rate, because the fetal heart rate is best heard over the fetal back. So you have to know where the back is. So when you're doing Leopold's maneuver, how are you going to know it's the fetal back? What does it feel like?
Firm,
It's
long.
Convex shape.
Smooth,
Smooth
right?
and
And it's smooth, it's going to be somewhat convex. There's going to be something of a curve to it, right? On the other hand, you're going to feel lumps and bumps. And what are those lumps and bumps?
Vertebrae.
So if
The
this,
hands and
this
feet.
side,
It's
right, this side is the back. This is going to be the hands, the
Gotcha.
feet, the knees, the
feet.
elbows, that's what you're feeling. Okay. So remember, the back of the head is going to be smooth. The back itself is going to be smooth, right? So then you have to think about your anatomy and you have to visualize what you are palpating to determine the sneeze that won't come, to determine so annoying, to determine the fetal position, because that's what it's based on, what you're feeling. Okay, so you have to be able to think, okay, where is the head? What does the head feel like? And what does the back feel like? Where are the extremities? So I want you to also think about what the head, the difference in what you're feeling if the head is flexed as opposed to if the head is not. So as you're feeling it, what part of the head are you feeling? Okay.
Okay.
All right, so let's go back to our slides now.
I have a question, like, how hard can you push on the belly? I never
Right.
want to touch a
Well, you're not going to hurt the baby. It might be a little bit uncomfortable for the mom, but so remember the uterine wall now, if we're at term, the uterine wall has started to thin a little bit. Remember how I mentioned that? The fundus becomes thicker.
Right.
The wall starts to thin a little bit, so it makes it a little easier for you to be able to do this. But you have to apply some pressure. You have to apply some pressure. Okay, so your goal here is to determine the position. So now you know where to place your monitors. Okay, all right. So back to talking about electronic monitoring. In comparison to palpation and auscultation, the electronic monitoring gives us much more information. So it lets us know how the fetus is responding to each contraction. There's an audio component to it. So hearing the fetal heart rate is often very comforting for the mom.
Professor, question for the so you said that before you place the monitors, you have to do the Leopold's maneuver.
You have to do Leopold's maneuver to know the position of the fetus.
And the
Because
heart.
fetal
So
heart
every
rate
time-
is best heard over the fetal back. But if you don't know which the position is, you won't know where to put your monitor.
Okay, so that's just standard procedure. Every time you put the fetal monitor, you start with the
At least initially when she comes in, at least initially, okay? So you know what position the fetus is in, then you know where to put your monitor. Okay, so
Advantages.
so it's less time consuming. You're over the patient less once you put them on the monitor. Now, on the other hand, she will have less mobility because now she's tethered to this monitor. She's not going to be able to get up and walk around as easily. Again, the technology creates more of a technical atmosphere. So I remind you again, you pay attention to the mom, even though the temptation is to just look at the machine. Remember that you are not taking care of a machine, you're taking care of a patient. And if she changes position, if she moves from her left side to her right side, you might have to reposition the monitors. You shouldn't have to do Leopold's. Usually you don't have to do a whole Leopold's maneuver again because the change in position is not going to be that dramatic. All right. So the equipment that we have, I'm going to go through this in relationship. Makes better sense to talk about it as we're doing it. So we can monitor internally, we can monitor externally, okay? And we'll talk about the difference in the two. So, and for most hospital setups, even though you have your patient connected to their individual monitors in their rooms, at the nurse's station, and very often within the patient's rooms, you can pull up the screens from other patients' rooms. So let's say you are in room 101 and you're wondering what's happening with the contraction pattern for your patient in 103, you can pull that up on the screen so you don't have to keep going into every single room. Or maybe you're at the nurse's station and you're gonna, you know, sip your coffee for a few minutes, you can bring up all of your patients and monitor what's going on. All right, so internal and then external. I'm going to, I think my slides have internal first, I'm going to talk a little bit about internal and then external, and then we'll talk about actually reading the strips, all right? So internal monitoring is typically done to get a more accurate picture. Again, external is less invasive, and we always try to do less invasive to more invasive. So we usually try, if we can, to monitor externally, but if need be, we will advance to internal monitoring. So internal monitoring, let's get, yeah, okay. Internal monitoring, there, again, you've got two patients that you're monitoring. So you need to monitor, if the mom is in labor, you need to monitor the contractions, but you also need to monitor how is the fetus tolerating the stress of labor, okay? How is the fetus tolerating the stress of labor? So if a spiral electrode is needed to be placed, it is usually placed, if the fetus is in a cephalic presentation, it is placed on the fetal head. If the fetus is breech, it can be attached to the buttocks if the fetus is breech. So a spiral electrode will give you the fetal heart rate. It gives you other information, but for right now, all I want you to know is it gives you the fetal heart rate. Now, it you might see, I'll come to that. It gives you the fetal heart rate, okay? Now, to monitor contractions internally requires an IUPC, an intrauterine pressure catheter, an intrauterine pressure catheter. So an intrauterine pressure catheter, just what it sounds like, a catheter that goes into the uterus. So it is inserted through the vagina, through the cervix, into the uterus. And it measures the frequency of contractions, the duration of contractions, and the intensity of the contractions. So it measures what's happening with the uterine activity. And it gives, because it is in the cavity, in the uterine cavity, it is giving you a much more accurate reading than an external monitor that reads the uterine activity from the abdominal wall, okay? This is actually inside, so it's giving you a much more accurate reading. Okay, I'm not gonna say any more about that. Now, if we're doing it externally, the fetal heart rate, we would use a fetal heart rate Doppler to assess the fetal heart rate. Again, after you do your Leopold's maneuvers, you know where the fetal back is. It is pressed, the fetal heart Doppler is placed on the maternal abdomen over where you have assessed the fetal back to be. To assess uterine activity externally, a tocotransducer is placed on the maternal abdomen. Okay, now, 2 external monitors here. My question to you is which is which? So tell me in the chat box, what's blue and what's pink? You've got 2 monitors, 2 external monitors here. So which one is the blue and which one is the pink? Which one's your fetal heart monitor? Which one's your tocotransducer? Let me open the chat box. I'm getting silence. That's never a good thing. Okay. So where would your tocotransducer be placed? So remember, the tocotransducer is monitoring uterine activity. So where would you place your tocotransducer?
On the fundo, on the fundus.
Fundus, no?
On the
Top.
thickest,
The top of the
strongest
fundus?
on the thickest, strongest part of the uterus, which
Yeah.
is the fundus. So the tocotransducer is going to be placed higher in this case, right?
Yeah.
It's going to be on the fundus. The fetal heart rate in this case is placed lower, okay?
Mhm.
So in this case, the lower monitor was the fetal heart Doppler, and the tocotransducer was the one that was at the top in this case. All right, so that's internal.
All right, can you show that last slide again? It's not in our stuff. Thanks. 1 second. Thank you.
Okay. All right, so just a reminder of, so this is an internal monitor. I'm not going to take the catheter completely off. This is an internal monitor. And I don't know if you can see, I'm going to do this so that you can see it. All right,
There is
so
a spiral,
I think in your next slide, you can see that there, or maybe the slide after, you see one that has like a little corkscrew at the bottom. Slide. So do you see this corkscrew here at the bottom?
We don't have that slide.
Oh, you don't have that. Well, that would be why you can't see it then. All right. This is, let me see if I can show you this. This is the part that goes to the fetal head. And then, so all of this would be in the uterus through the cervix, and then this is what attaches to the monitor. So this end actually looks like a corkscrew. It actually looks like a corkscrew. And I can't get this so that you could actually see the point, but each monitor being placed on the fetal scalp. This is what I just showed you. So the scalp electrode is here, and this is your IUPC attached to the monitor. So this is your replaces your tocotransducer. This is giving you information about the contractions. And this one is giving you information about the fetal heart rate.
So Professor, the mom has nothing monitoring, like nothing on her belly, right? It's all
Correct,
okay.
correct. Everything's internal. So this mom is definitely not getting up. right? She's not going anywhere because she's got both of these internally inserted.
So
Okay.
Professor,
Is
we
this
do
a
only
prenatal exam or it's just
This is a
before
mom that's in labor.
or in labor?
In labor. So remember, this is intrapartum monitoring for how she is doing, what's happening with the labor and how the fetus is tolerating it.
This is the first stage.
Yes. Mhm. First stage.
So Professor, it's either or. It's either external monitoring or internal monitoring. You don't do both of them.
So you might do both. It's a little bit unusual, but let's say you have a, you might have one internal and one external, but usually you don't mix them like that. I mean, the thing is, if you're going to place one monitor internally, you might as well just place both internally. So for better accuracy. So it's usually all internal or all external. Occasionally you'll see a mix, but it's usually one or the other. Okay. The important thing to remember is whether it's internal or external, one is monitoring contractions, one is monitoring the fetal heart rate. And remember, internal gives you more accurate readings than external. The other thing that I will say to you is that internal also gives you information about, accurate information about the intensity. External gives you information about the intensity, but we don't really consider it that accurate. All right. Okay, so let's talk about contractions here. We talked, and some of this we discussed already, right? We talked about this with labor. The increment, it's the same contraction pattern, same contraction cycle. The increment is the building up. It's the longest phase of the contraction cycle. The acme is the peak. And then you have the decrement, the letting down phase of the contraction. So this is the same. This is actually the same slide that we went over yesterday. Duration the same, frequency same, information, resting interval, all of that is the same. Okay, same exact thing we talked about yesterday. But now we're going to evaluate it. So this is what a strip looks like. So you might have a strip that's like this. You might have a, you might have 1, 2, 3, 4, 5, 6. So between this bold line and this bold line, this is 1 minute. So that is how you are going to distinguish the time. You have each box is 10 seconds. And these bold lines will separate your minutes. Okay. So are we good with the plain paper? I want to make sure before we start adding things. Okay. Now, when you look at a strip, again, this is 1 minute. These bold lines separate the minutes, but you know that you can count 1, 2, 3, 4, 5, 6. Each box is 10 seconds. So 6 of them is 60 seconds. So between the bold lines, you have 1 minute. Okay. Now, regardless of who manufactures the paper, the upper pane, this upper part is always the fetal heart rate. The lower part is always the contractions. Okay. So I will remind you, fetal term fetus, the normal heart rate is 110 to 160. So when you are looking at the rate, you should be using these numbers to determine if the fetal heart rate is in the correct range. Okay, so you can see that this, the fetus that we have this strip for is like in the 150s. All right. Okay. So looking at this strip, what can you tell me about the contractions? And I don't know is not an option. What can you tell me about the contractions? What do you think about this contraction pattern? How often are they coming?
Regular.
So I'm going to ask you to put it in the chat box just so that I can make sure that I'm getting all of you. How often are these contractions coming? And it's going to be, so I need more specificity than that. So a little bit over a minute, yes, but so if you have contractions, you know, contractions in general do not come every 1 minute or every 5 minutes or every 2 minutes. So usually you'll have a range. So yes, about 2 to 3 minutes apart, something like, so you might have a couple that are 2 minutes apart, some might be 3 minutes apart, but whenever you're responding to something like that, it should be in a range, okay? So every 2 to 3 minutes or whatever. Now, I know this one might be a little bit hard to see, but again, you're using these lines to differentiate the minutes. I have some slides that are a little bit easier to see. So what would you say about this fetal heart rate? It's somewhere in the range between 120 and 150. So the fetal heart rate is within the range that you want it to be, okay?
And it seems that it's accelerated with the contraction, can be or not?
So
At least
we are going to talk about interpreting the strip in a minute, all right? So initially, you're just looking to see what is going on, right? Well, we don't know that much about the mom, so we're guessing that she's in pain, but we're not looking at her rate. We're just looking at the fetal rate for now, okay? All right. So when you monitor a contraction pattern, this is what I want you to monitor for. The contractions should not be closer than 1.5 minutes apart, right? So you have to, when you look at them again, you need to count your boxes so that you're making sure that there is adequate resting interval. So again, this is an increment, this is a peak, this is the decrement. That means this is a resting interval. So this, if we're counting between this contraction and this contraction, you can see that there's a little over 1 minute. I'm sorry, a little over 2 minutes for the utero-placental unit to reperfuse. This is your resting interval. This is your resting interval. You always want a resting interval of at a minimum of 30 seconds. And on this slide, we had more than 2 minutes. So that's plenty of time for the utero-placental unit to reperfuse.
Professor, so resting interval is same as a pregnancy, right? How often you gotta see how many minutes resting interval?
No. So unless I misunderstood you, this is the contraction.
Yes, I know.
This is the contraction. This is your resting interval, the time in between.
So you were asking us like, what was a resting interval before? Was it? Oh.
No, I was asking you how often the contractions are coming.
So
that was a different question.
Yes. So that's why I counted this almost like about a little bit over 2 minutes because the resting was a little bit over 2 minutes.
Yeah, the resting is a little over 2 minutes. Yes.
That's why I put in like a little bit over 2.
Oh, okay. Before I was asking about the frequency, how often are the contractions coming? That was a different question. Before I was asking about how often, about the frequency.
Yes, that's why I counted like that. How?
But when you're counting the frequency, you're counting from the beginning.
Mm-hmm. So 1, 2
to the beginning.
So it's beginning to beginning, not peak to peak.
No, it is not peak to peak. Remember I said yesterday,
Yes,
frequency. So go back to your contraction cycle.
Got it.
The frequency is the beginning to the beginning,
oh, that is a
not peak to peak. It is the beginning
to the beginning. So
to
whole
the beginning. That is your frequency.
Oh, okay. Thank you so much because I was
Okay.
kind of resting that one. So,
Right.
oh, okay, I got it. Thank you so much. Now
You're
clear.
welcome. Okay. So always refer back to this to clarify. All right. The duration is the contraction, the beginning to the end, but the frequency is the beginning of one to the beginning of the next, to the beginning of the next, and so on.
Professor, when you said that contractions should not be 1.5 minutes apart, not like even as she gets close to delivering, they don't ever become that close.
You're concerned. That
Oh.
is when you're concerned.
Okay.
Okay. That's where you're concerned. You don't want them longer than 90 minutes. Oh my gosh. That would be some contraction. 90 seconds.
Nobody,
No,
nobody more.
that would do us all in, like 3 people down, you'd be able to feel that. An hour and a half, my God. Okay, so contractions longer than 90 to 120 seconds, too long. Because remember, these long contractions, the longer the contraction, the less oxygen that's getting to the fetus. And remember what, I want you to remember though, it's not just, oh, you know, it's oxygen to the fetus. We're talking about the brain. If the fetus isn't getting oxygen, the brain is not getting any oxygen, okay? Its fetus is going to have lifelong problems. So this is really, really crucial. We want to make sure that the contractions are not too long, that they're not coming too frequently. We want to make sure that there is adequate resting intervals so that the uteroplacental unit can reperfuse. And this last bullet is very important as well. You want to make sure that the uterine muscle relaxes. Because if it doesn't completely relax, the uteroplacental unit will not reperfuse. So even if you have an adequate resting interval, even if the time is adequate, if the muscle is still somewhat contracted, the uteroplacental unit will not reperfuse. Okay, so you need the muscle to relax with enough time for the reperfusion to occur. Okay. All right. So we're good with our strip. Everybody good with our strip? I wish we, you know, usually in class I pass out strips and then we can make our own contraction patterns, but we'll make do. Okay. So that's what you're looking at your contraction pattern. Now, when you're looking at your heart rate, I want you to look at it for the rate. 110 to 160 is normal for a term baby, but a preterm baby may have a preterm baby may have a little bit of a faster heart rate, which is normal, So just to give you a point of comparison, what is your heart rate right now, all of you? What's the normal adult heart rate?
80, 100
60 to 100.
60 to 100.
ppm.
So you should be somewhere in, most of you were probably somewhere in the 70s to 80s. If you think about it, you started out at 110 to 160. And as you get older, as your body matures, as the central nervous system matures, the heart rate goes down, which is what it should do normally. So if you think about it, a preterm baby is going to be above 160, and that is normal. Okay, but I'm not holding you to that now. I just want you to keep that in mind because we'll come back to that point. But when you're looking at the fetal heart rate, you're looking at the rate, you're looking at regularity, and then a variation from the baseline. Now, even when the fetal heart rate is in the normal range, even for those of you, you're sitting, you're typing, you're writing your notes, your heart rate is not 80. It's somewhere ranging between 78 and 84. There's always a range, okay? So even when the heart rate is within what you expect, there should be some fluctuation. There should be some fluctuation. You don't want to see just 80 straight across. That is telling you there's something wrong with the central nervous system. There should be some variability, okay? So the fetal heart rate, I already told you, 110 to 160. Same terminology, even though the numbers vary from the adult ranges. Bradycardia, less than 110. Tachycardia, above 160. As I mentioned, a higher rate is normal for preterms. Now, variability, I am not going to hold you to understanding the intricacies of variability. However, I expect you to understand what variability is and that there should be some variability, all right? So, okay. What do you think of this heart rate up here? This one at the top of the screen. What's your thought?
There's
Is
no
that a
way.
good thing?
No.
Low activity.
It's not normal.
So
No.
it is in the normal
It is normal.
range,
Okay.
right? It's a fetal heart rate of 150. It's in the normal range, but there should be some variability. The fact that there is no variability is very concerning. This is telling you that there's a central nervous system problem with this fetus, okay? What you want to see is something like this, the bottom strip. You want to see some variability, okay? Always. All right, so now, so that is what I'm going to hold you to. I'm not going to hold you to understanding all the differences between short-term and long-term and all of that. But you have to understand that there should be some variability. If you don't see it, you're concerned, and that there might be a problem with the central nervous system. Okay, all right. So bradycardia, what's your thought here? Do you look at this strip and think, okay, this is good, I can go to lunch, no problem. Everything looks nice, I'm happy.
Way too low.
It's dropping very low.
It's extremely concerning, right?
Yeah.
This baby's baseline was 80 beats per minute, which is about half of what it should be. And then he had the nerve to drop to 60, he or she, right? Serious misbehaving happening here. So real misbehaving. We're not happy with this. All right. But that's what bradycardia looks like.
What could
On
be
the other
causing
hand,
this?
I'm sorry.
What could be causing the bradycardia?
Baby more than likely has a cardiac defect and quite likely a central nervous system.
There's also a very short resting period between those two contractions.
Between these two contractions. Yeah.
Correct.
Yeah. This whole picture is not good. Tachycardia, this fetus is tachycardic to in the 180s, and consistently, more than likely, this fetus has, and there's an intrauterine infection. This kind of heart pattern is indicative of intrauterine infection. So what would you expect your coat assessment to be here? What would your coat assessment be?
Color, other.
So the color might be what? Would it be straw colored? It might be
Darker.
Yellow, darker.
might be yellow. It might be cloudy. What would you expect the odor to be? It would be malodorous, right? So again, I want you to start pulling your assessments together. Pulling your assessments together, because you know the information. I just want you to start thinking about how all of this comes together. Okay. All right. Okay, we're done with that. We talked about this already, variability. Beautiful. Okay, just a reminder. All right. So this is a reassuring pattern. Now, when we talk about contraction patterns, we do not talk about normal or abnormal. We talk about assuring or, reassuring and non-reassuring. And it's just what it sounds like. A reassuring pattern is a pattern that you're comfortable with, what you see, you're not concerned about. Non-reassuring is just what it sounds like. You're not happy, you're not assured with what's going on, okay? So this is a reassuring pattern. The fetal heart rate is within the normal range. You see some variability here. The contraction pattern, you have adequate resting intervals. The contractions are not too frequent. They're not lasting too long, okay? This is reassuring. This is reassuring. All right, now, we'll start talking about the specifics. An accelerations in the fetal heart rate are to be expected. Accelerations are to be expected. They are usually brief. They're usually temporary. We might see them due to a contraction. You might see them due to a vaginal exam. Let's say the provider goes in and is checking for dilation and effacement. So accelerations, the fetal heart rate increases. That is to be expected. And then we will talk about the types of the three types of decelerations. So an acceleration, predictive of adequate fetal oxygenation to be expected. Let me see. Okay. So here's an acceleration. You will also see accelerations with fetal movement. Okay. Like you start moving, your heart rate increases. So this is an acceleration. And here is an acceleration. In both instances, the fetal heart rate increased and returned to baseline.
Professor, is this the same as we saw in the testing, like the stress, test for the baby that says 15 BPM at each movement? It increases or not? We are talking about a different thing.
Talking about a different thing. We're talking about something different. Okay. So now, even though the non-stress test and your biophysical profile uses the same equipment, but we're talking about something different. So these are both accelerations. Now, in this one, the fetus was, the heart rate accelerated, not necessarily in relationship to the contraction pattern. In this one, you have an acceleration here in relationship to this contraction. All right. What we are more concerned about are decelerations, and depending on the type. So decelerations, early decelerations are caused by fetal head compression if the fetus is in a cephalic presentation. Early decelerations require no intervention. They are to be expected. They do not require intervention. The fetal heart rate decreases at the beginning of the contraction and it returns to baseline at the end of the contraction. They are consistent in appearance. So basically an early deceleration mirrors the contraction. As the contraction is going up, the fetal heart rate is going down. And as the contraction is releasing, the fetal heart rate is returning to baseline. So these are early decelerations. These are early decelerations. So if you were to draw a line from the peak of the contraction, which is here, which is here, to the lowest point that the fetal heart rate drops, you would have a straight line, okay? And the nadir, I just wrote it in the chat box, that is the lowest point that the fetal heart rate drops. So you could actually draw a line from one to the other. This might be better for you to see. You can actually draw a line from the peak.
Professor, what can cause this, like fetal distress?
This is what you are expecting. I just said this is an early deceleration, right? Early decelerations are caused by fetal head compression. They are to be expected.
All right.
No intervention is necessary. No intervention is necessary, okay? So those are your early decelerations.
Professor, but the nadir is in general, right? For all decelerations, not just for the early ones. It's
Right,
the
no,
lowest point
but
in
it is, remember what I said it is, it's the lowest point that when the fetal heart rate drops, it's the lowest point.
Right, I understand, but I'm just saying that's consistent for all the
Yes,
the
for all of the all types of
the
deceleration.
Yes, thank you.
Okay, so those are our early decelerations. So here's some more early decelerations. So some are going to be more dramatic, let me see, than others. So again, early decelerations are a reassuring pattern. Usually we will see them in relationship to a contraction. They might happen with a vaginal exam. On the other hand, you might have an acceleration. But basically, again, to be expected. No intervention is necessary. So let's say you're monitoring a patient and you see early decelerations. What should you do? I know you're going to think that's a trick question, but it's not. What should you do? Patient has early decelerations. What are you doing?
Nothing.
Nothing.
Just monitor it.
Taking a coffee break.
So
You can turn the patient to the side.
a nurse never does nothing.
A vaginal exam?
If you don't remember anything from me, a nurse never does nothing, okay? Always, even if your patient is doing exactly what you expect, you are reassured. This is a reassuring pattern. You're feeling good. It is always continue to monitor and document. Okay, always. In any situation, it's always continue to monitor and document. So if you peek in, let's say the patient is taking a nap. She's on the monitor, she's in labor, she's comfortable, she's taking a nap, she's resting, she's comfortable. You see early decelerations, you are going to continue to monitor and you're going to document. Okay? All right. Now, late decelerations. These are your problem child. This is your problem child here. Late decelerations. Late decelerations are caused by uteroplacental insufficiency, which is just what it sounds like. You are not getting sufficient blood flow, not getting sufficient oxygenation through that uteroplacental unit. They are a non-reassuring pattern. So anytime you see late decels, forget the coffee break, forget lunch. It's not going to happen right now, okay? You are concerned about this. So in a non-reassuring pattern, the nadir where the fetal heart rate drops, it happens after the peak of the contraction. It's just what it sounds like. It's late. Now, by comparison, the word early is a little bit deceptive when we talk about early decels because they actually happen at the same time, but I didn't name these things, okay? I didn't give the names. These are the names that I found. So late decels, the heart rate drops after the peak of the contraction. So when you're looking at your slide, looking at the screen, you can see that the contraction already started, right? The contraction's already peaking, and then the heart rate drops. That is concerning. That is concerning. So anytime you see late decelerations, you should be thinking uteroplacental insufficiency. Now, that may be due to hypertension, it may be due to diabetes, it could be due to supine hypotension.
About the cord.
The mother could be hemorrhaging, but you know something is wrong. You don't want to see this. If you see late decelerations, you have to act. Okay? So your concern here is a lack of oxygenation to the fetus. And so your interventions are going to be around correcting that. So late decels, here's some more late decelerations for you. This one is not as marked as the previous one. This one's, you can see a little bit more clearly. Let me see. So there's some late decels here. Okay, so as you can see, a whole list of things that can cause late decelerations, right, in the patient's history. But all of these things, uterine tachysystole, maternal supine hypotension, epidurals, previas, abruptions, hypertensive disorder, all of these result in uteroplacental insufficiency. So for right now, I just want you to remember uteroplacental insufficiency, okay? So tends into your question, this is even though the fetus has all of their extra H and H and they have their fetal hemoglobin and all of that good stuff, this is still happening, okay? So you're concerned about this, all right? So again, early decelerations, head compression, normal, to be expected, reassuring, you're good. Late decelerations, uteroplacental insufficiency, you have to do something. Okay? All right. Now, remember that what you want to do is improve oxygenation to the fetus. So your actions are going to be based on that. All right? Your actions are going to be based on that. So you want to optimize placental circulation. So you want to change the maternal position. What position so I'm going to ask you to put in the chat box, what position are we moving this mom to? What's your optimal position? Ideally, where do you want to put her? Put it in the chat box, please. Left. Right. Left lateral recumbent position is going to optimize perfusion to the placenta. First thing you do, put her on her left. Okay. Then you want to increase the circulating oxygen. So increase her IV solution because you want to expand the vascular volume. So whatever oxygen she has, you want to get that moving. So tachysystole, tachysystole is contraction, or this is referring to excessive uterine activity. So contractions that are too fast, too long, too intense, lack of a resting interval. Oops, sorry, that's what that is referring to, okay? So if you palpate to assess for tachysystole, what might you find? What might that uterus feel like? If the contractions are really intense, what might that feel like?
Your forehead.
Forehead.
It's going to feel like your forehead, right? So when you palpate that uterus with your fingertips, it's going to feel hard, like your forehead. If she has oxytocin infusing, we're going to talk about this next week, so I don't want to get hung up on this right now. But if she has oxytocin infusing to induce the labor, or to, sometimes we give oxytocin to make the labor contractions more effective, it may be too much. You know, we all have our own individual metabolisms. And so what one person, the way one person may metabolize a medication, that might be too much of a dose for another person. So it's completely possible that if she has oxytocin infusing, that is what has caused the tachysystole. So we need to stop the oxytocin if it is infusing. We certainly want to give oxygen, notify the provider. She may need internal monitoring for more accurate assessments. But if this pattern cannot be reversed or corrected, she may need to be delivered by cesarean birth. Because again, the longer this goes on, the more you're impacting oxygenation to the fetal brain. And we never want to compromise that, okay? So.
Professor?
Yes.
Why don't you just show me the list, that intervention for notified doctor? Is that a kind of a step by step? And so it didn't work, then we finally, after.
Okay, so here's the thing, with a late deceleration, I want you to think about, it's caused by uteroplacental insufficiency, right?
Yes.
So your goal is to optimize placental circulation and fetal oxygenation. So everything you do is based on that, okay? So that's what you're thinking. So your first thing is put her in the left lateral, right? We've got to maximize, optimize, improve placental circulation. Put her in her left lateral. Okay, she has an IV going, increase the rate. Let's get some fluid circulating and get whatever oxygen she has on board circulating. Maybe she doesn't have oxytocin. She doesn't have an oxytocin drip. That's not on you. Then you don't have to do that, right? If she doesn't have it, you don't have to do that. So you would then put her on oxygen. But if she's already on oxygen, what if she's already on oxygen and she's on 2 liters? You might need to increase it. So it's hard for me to give you an exact list because every patient is going to be slightly different. So if she's already on oxygen, you might have to give her more oxygen.
So we tried all of the intervention, and then it doesn't change anything. Then we lastly we notified the MD. Is that what it is?
So you need to. So here's the thing: you want to do whatever you can within your scope of practice before you call. So if you look at this strip and you see late decelerations, and you go to and notify the MD. You walk down the hall and you tell, oh, my patient's having late decel. You know what the MD is going to say to you? And Jinhee, what did you do? And then you're going to stand there like, I don't know. You know what I mean? You don't want to do that. So you want to do whatever you can, always within your scope of practice. You can certainly turn the patient, right? Increase the IV rate. So that sort of thing you can do, because usually you will have orders that cover that. So you can say, when you go out there, you can say, the patient's having late decelerations for the last 3 minutes. I put her on her left. I increased the IV rate. I gave her the oxygen. No change. Right? So that's a more. Okay. You're welcome. All right. So again, you're doing what you can do within your scope of practice. Changing patient position is certainly within your scope of practice. You can increase the IV rate, and usually oxygen, although it's a medication, this is very similar to any kind of cold-like situation where you can give a patient oxygen if they need it, right? You will, that order you'll be covered for that. Okay, so that's late decelerations. I want to at least get to variable. So variable decelerations are usually caused by umbilical cord compression. So just thinking about that, if the cord is being compressed, what might you need to do?
Take the baby out.
No, even before that.
Try to move the baby.
The easiest thing.
Try to move the baby, no?
Move the position of the mom.
How do you move the baby? You move the mom.
Now.
You move the mom. You change the mom's position. You change the mom's position. So very often, again, this is caused by umbilical cord compression. Maybe she's laying on her left side. You put her on her left side for to maximize placental perfusion, but maybe the way the baby has positioned themselves, the cord may be trapped between her pelvis and the baby, right? So now you need to move her to her right side to relieve the pressure on the cord.
But Professor, didn't we say variation is good on a fetal heart?
Say that again?
But didn't you say variation is good?
I said the variation is good, but here we're talking about variable.
So
which is different from variability. Where are we?
It's a small difference. If it's
it's a huge.
Okay, got it.
Huge. So yes, it's a small difference in the spelling, but I want you to understand the difference. Trust me, this will make a difference to your life on Tuesday. You have to understand the difference, okay? Because I'm sure I will ask you a question about this. So variability, you want to see some variability in the heart rate. You don't want to see variable contractions. Does that make you happy? You don't want to see variable decelerations. You don't want to see this. Okay? These are variable decelerations.
Okay.
You certainly don't want to see those, right? And this baby, look at this, down to 60. Down to 60. Yeah, this is not good. Okay? So as soon as you see this, you need to be moving this mother. Okay?
Professor, I have a question. So if we are expecting to see some minor changes in the fetal heart rate, what's like
some variability? So you want to see some variability, maybe between 5 and 10 beats per minute.
Okay, that's what I was going to ask. Like, how many beats per minute is acceptable? So 5 to 10.
Yeah, in that range. You want to see like in that range. This you don't want to see. Okay. This baby went from like 160 to 60. Okay. That's a huge drop.
Professor, a question.
Right? And the baby was that low for 20, 30, for like 40 seconds. Yeah. That's a long time. You don't want to see. This whole strip is crazy. Right? You don't want to see this. This is not what you want. This is not, you don't want this one either. Okay? Even though this does not look as dramatic, you don't want this.
But how long do you wait? I mean, after you change the position of the mom, how long do you wait? How many days?
To make sure that you've corrected the position, whatever the problem is. It might correct in 20 seconds. It might take 10 minutes. You have to stand there. This is why I said to you, remember when we looked at late decelerations, what did I say to you? When you see this, you're not going on break and you're not going to lunch. I think I said that, right? So you got to stay there. This is the nature of labor and delivery. Things can change very, very quickly. And you can't move. You can't move. So you do what you need to do. You make one change, you see if it works, you make another change, you see if it works. If it's not changing, then you have to notify the provider. So in the case of variable decelerations, again, look at this variable deceleration. Very low, very long, okay? So variable decelerations are typically caused by umbilical cord compression. So you need to reposition the mom and then see what happens. All right. So again, in answer to your question, Simona, you might stay there for 5 minutes to make sure she's okay. But if it still keeps coming, then something else needs to be done. You might need to call the doctor and come, notify them and come right back. You can't leave them. Okay. All right. Just as a reminder, one of the other reasons that an umbilical cord might be compressed, and I alluded to this earlier, is a lack of sufficient amniotic fluid. So a lack of sufficient amniotic fluid, oligohydramnios, could be a cause for cord compression. So if the mom comes in and she's in labor and you look at her history and you see that she has oligohydramnios, you should be monitoring her very closely for variable decelerations. Now, one of the things that might be done is an amnio infusion for her, okay? To infuse fluid in to expand the volume of amniotic fluid to decrease the chances of this happening.
Sorry, Professor, so you said oligohydramnios is a cause for compression.
Well, oligohydramnios, right, is if you don't have sufficient fluid for everything to float around, the cord can become compressed.
Okay.
Right? So she might need an amnio infusion. Okay. Yeah. That can be one of the reasons.
Professor,
okay.
And the maternal position is switched to the lateral recumbent as well?
It depends. You might change her to the left. You might change her to the right. You might need to put her on hands and knees. You might have to change. Sometimes you don't know where the cord is being compressed. And so you might have to move her a couple of times and keep checking the monitor to see which position is better for the fetus. Okay, so we are out of time. I didn't get to the summary slides, but the summary slides just go through what I pretty much just said. But I'm going to end here and ask you if there are questions.
I have an overall question. Sorry. Is this the last class for this subject matter for the test on Tuesday? You're muted.
Yeah.
Sorry, I didn't hear you anyways. I saw you.
No, I said yes. I'm not muted. Yes.
All right. So we didn't get a chance.
So there is a little bit at the end here.
Yeah.
That will go on to the Unit 2 exam. We'll finish that on Monday, and that will go on the Unit 2 exam. But everything I covered today will be on the exam on Tuesday.
But not postpartum changes that we're doing on Monday.
No, that was not on the list.
So you wanted me to
go back to the list that I gave you. The list that I gave you ended today.
Okay.
Gotcha. So one, we had talked right before class about talking about parsing down the data to study for the test on Tuesday.
Okay.
And you wanted me to remind you about the pharmacology stuff.
About the pharmacology. So, okay. So I know everybody's thought is, oh my gosh, how am I supposed to get all of this in my brain for an exam?
It's a high level of anxiety for everybody.
I don't understand why. Yeah. I'm joking. I totally get it. I do. I totally get it. I'm just having a look very quickly at your med list. That's an easier question for me to answer. Okay, so your medication list for Unit 1 has oxytocin, Pitocin, which, what have we talked about it? What I just said, it's sometimes used for induction. It probably honestly won't be on the Unit 1 exam. It will be on the Unit 2 exam, but it would only be what I've said. It's used sometimes for induction. It can cause the contractions to be more intense. That's all I said. RhoGAM, we give that to moms who are RH negative. If the mom is Rh negative and has an amniocentesis, has a CVS, has any procedure that might result in mixing of maternal and fetal blood, we need to give RhoGAM. That's
May
all
I
we've
ask
said.
you, Professor, about this? Every mom who is negative, or if the parents both are negative, you don't do it?
If the mother is negative.
Negative and okay.
The mother is negative.
I have a question. For the mom who's negative, I know they will have the screen test on the first prenatal visit. Once they find out it's negative, do they give RhoGAM right away, or they wait until
No, the RhoGAM, remember, RhoGAM is given at 26 to 28 weeks, and then after the baby is delivered.
Okay.
Okay. But basically for Tuesday, if the mom is negative, I just want you to remember the basics. If the mom is negative, if there's any chance that there may be mixing of maternal and fetal blood, she needs to be treated. That's RhoGAM. Rubella. What have we talked about the rubella vaccine?
It's a live
vaccine. You can't give it during pregnancy. You have to give it in postpartum. You have to, you know this, you know rubella, you know what I might ask you. And then the other thing, it was your anti-infectives. The only one on the list that I think we talked about is penicillin. And what did we say we would give penicillin for?
Yes.
If the mom is GBS positive, we're going to treat her with penicillin. There's your med list.
IV, right?
That's your unit 1 med list. I'm sorry? IV, yes, IV. Okay, now, I had a slide, but okay. Let me just find the slide that I was supposed, I know why we didn't get to it, because we didn't finish the class and I put it at the end. So let me just pull it up. And where is it? Hang on one second, I'm sorry. Okay. Where is it? It's not allowing me to share this one slide. Oh, why it's not coming up. Okay. Oops. There it is. It's on page 2. As you know, there's certain things you have to know your A&P for, right? Which we've talked about. Make sure that you review your notes from class. I've encouraged you before to make sure that you review them. Those of you who are taking notes by hand, that you rewrite them so that you can understand what you wrote, because I know sometimes you write it quickly. The main handouts, the podcast, the nutrition podcast, and the prenatal history podcast, assignments. So which assignments? The main assignments that I'm talking about here are the matching for the tests and what we talked about with Catherine. Okay, that's really all that we've done so far. And of course, the information reinforcement that you've gleaned from the F.A. Davis. So apply the concepts. Now, talk about applying concepts. It's things like what I just mentioned to you. If you think about what is happening with the patient is having late decelerations. You know that's caused by uteroplacental insufficiency. Your concept, your goal is to maximize fetal oxygenation. So that should tell you right there what you need to do. Everything flows from that. So it's really understanding what is the problem, what's at the core, what is the problem, and what I need to do. And what I need to do, okay? It's about making sure that you understand the concepts. Now, I told you on the first day, you know, the days of memorization are over. The only thing you're memorizing after you leave fundamentals, the only thing you memorize are vital signs, labs, and, you know, like number ranges like that, right? That's it. Everything else has to be a deep understanding the concept and then applying the concept. Okay, so that's, I think that is really going to be your challenge here, is making sure that you really have a deeper understanding and that you're able to apply the concepts. I have not checked today. So only the lab values that I might have talked about. What if we sources? And you know, I can't control that. If you want to do questions from other sources, my recommendation is that you make them reputable sources, not just vague questions off of Google, because some of those questions are not accurate and the information is not accurate. So if you're doing questions that are outside of F.A. Davis, Saunders, Mosby, the other one I want to say.
Difficult.
There's a specific Lippincott that I'm thinking of that I can't tell, but Lippincott, but make sure that you're using reputable sources, okay? Google is not reputable, right? Any and everybody posts all kinds of things on Google. When you are doing questions, not just for this course, but going forward, always read and understand the rationale. So if you read the rationale, even if you get the question correct, read the rationale, because you will always learn something from the rationale, okay? And if you need to, sometimes you find something that makes something I might have said or something you read even more clear, even take that note and add it to your class notes so that you have everything in one place, okay? When you're doing questions, make sure that you're doing more application level questions. The questions that I've selected for you in Davis are mainly application level because I need to, you know, you need to get used to that level of questioning.
So Professor, since Davis does allow us to make our own quizzes, those are good questions for us to work on, right?
They are, so make sure that you are doing, I think even on the student level, they're easy, moderate, and high, if I remember correctly. So try to do more of the moderates. I know the easies are easy.
Yeah,
maybe that's what you do to kind of warm your brain up, but then get yourself into, really lock into that moderate level. Time management is, I'm going to try to hold it to 50 questions. As I said, even if I give a couple of extra questions, which I will sometimes do, I add on time for those questions. But what I find is if you're not aware of the time, if you're not managing your time carefully, you will realize that you're only at question 30 and there's like minimal time left, okay? So be aware on Tuesday, be aware of the time. I don't make announcements about the time going, you know, constantly, because I think that disrupts your train of thought. But I will start announcing, usually I start announcing time at either 20 minutes to or 15 minutes. And I'll do like 5-minute increments, okay? But as you know, you have an hour and 15 minutes. I'm not going to tell you, you have an hour and 10 minutes, you have an hour and 5 minutes, because that's just gonna make you crazy, right? I'm not going to do that. But I will post so that you can see the countdown of time. That's usually how I do it. I started at 1 hour and 15 minutes, and then you can see the countdown on the screen. All right, but time management is going to be important. 2 more things. Yes, there will be 5 medication calculation questions. For those of you who don't have a problem with that, just do those first and get them out of the way, right? I think sometimes if that's your area of strength, it kind of gives you a little bit more confidence and you feel better going into the rest of the exam. You will have calculators, I will bring scrap paper for you, so you will have that.
Can you give us any indication of the types of math questions, like the level of difficulty? Like, are you going to give IVs? Are you going to,
I have no idea because I have done absolutely nothing for the exam. I will not do it until tomorrow. Like, I need to teach first.
I got you.
There definitely will be something IV-esque on there. Other than that, I don't know. I will try to post the blueprint as soon as possible, and I might give you a range of an idea of the types of questions, even if I haven't written the questions, but you'll have an idea of the type. There's something else I was going to say. Oh, I already said that. If you choose to do the math, you do that first. That's your choice. The math calculations are calculations. They will not be on the Scantron. They're not multiple choice. So you have to do them, circle your answer, and that's that. Okay. What else did I want to say? Scantrons. So let me think. Last semester, all your exams were on Blackboard, right? And for psych, all of your exams were on Blackboard.
All of them so far.
Okay. So my exams are going to be on the Scantron. I don't have one here, but you know that bubble sheet that you have to complete? All right. So let me say two things. Your exam booklet is your booklet. If you want to draw pictures all over it, it's yours. I don't care. I find that sometimes for students, like if I ask you a question about position, you might need to draw something. It's your booklet. If that's what you need to do, do it. If you need to circle the words, like if I ask what is the most significant or what is the most important, what is the priority, it sometimes is helpful for you to highlight that word or circle that word. It's your booklet. You do whatever you want, whatever helps you, do that. My only request is that the answers make it to the Scantron, because the policy is that this is the grade. Okay. So I had a student a couple of years ago that did the exam and gave me this blank. And I had to go by policy, and her grade was this. So please, let's not do that next week. It wasn't very good for me. Okay. It was very, very upsetting. So I will make sure, I always factor in you have enough time to do it, and I will remind you, especially since you guys are used to Blackboard, I will remind you to do it. But I'm going to tell you right now, don't wait until the last minute, because if you're one number off, your whole exam is going to be screwed up. Okay. So I want to make sure that you have enough time to do that. When you rush and do it, it throws it off. All right. So make sure. So if you want to do question by question, if you want to do all the questions in your booklet and then go back and fill in your Scantron, whatever works for you, just make sure the answers make its way onto the Scantron, please. All right.
Professor Scantron, we can use a regular pencil or a pen?
Pencil. So please bring a pencil with you. A pencil.
Thank you.
Yes, please bring a pencil. So other questions? You guys you actually know a lot more than I think you're giving yourselves credit for. Okay. So again, I said this earlier and I will say it again. This is not it's not that you have this hodgepodge of all of these miscellaneous things. Think about how you're bringing these things together. Okay. Think about how you're bringing these things together. Last week for clinical, we had that adolescent patient. So remember how you talked about how her diet was going to be important to this baby, how this baby grows, how her body heals in the postpartum period. So you have the pieces, you just have to start thinking about how they all fit together, okay? How they all fit together. All right, so the discussion board, I don't want to keep you too long. The discussion board will be open. I think I answered I answered the questions that were posted over last night. Don't get lost in the weeds. Don't get lost in the weeds, okay? And remember to prioritize. Your priority is always going to be fetal oxygenation, right? So what do I have to do around that, okay?
I did have one question, sorry.
Yes.
Priority labs out of all that stuff. I mean, there's so many labs, like what do we really need to have ready for that?
So it's going to depend on, well, think about your patient. So you know the ones that you have to know for a pregnant patient, right? The blood type, CBC, HIV, hepatitis, that list that we've been going over and over, right? Those are the main things that you need to know. The H&H, we've talked about how that can fluctuate, but you have to expand your assessment. You have to use other information. What other labs were there? As far as the tests, is that what you mean? The antepartum testing, the amnio? So you have to think about this in terms of what would you do? If it's a patient that is 52 and this is her first pregnancy, what's your concern? Chromosomes. What tests is she gonna need? An amnio. She's Rh negative. She needs RhoGAM.
Professor,
You do the amniocentesis, you got to give RhoGAM right then, right? So I want you to pull, do you understand what I'm saying? I want you to start thinking in that way. I know it's a lot. I know that it is a lot.
Like for you said, certain thing we have to memorize is like memorize. So we have to know each trimester's week, what week we gotta do this screen, what week this diagnosis. We have to know each one like exact week.
So think about things that like, okay, even if you get lost in, let's say you can't remember exactly how many weeks a CVS should be done, right? The chorionic villus sampling. You don't remember how many weeks, but you do remember the amniocentesis.
Yeah.
Okay. You know that there's some similarity between them. Which one can be done before the other one?
CVS before.
And that's all you would need to remember, really.
Not like a 10 to 13.
Don't, but
you can like.
So the thing is, I don't want you to get so caught up that because also once you're in the exam, if you start everything just flies right out of your brain. But if you get to a question like that and you realize, I can't remember this, but I can remember that, how can I use this knowledge to answer that question? Okay. I don't remember how many weeks, but I know it's before that. Okay. I know it's before the amnio. Okay.
Professor, may I ask something about Catherine, the fact on the diagnostic? It was only the ultrasound to do it because we didn't, for the polyhydramnios, you don't do the amniocentesis, do you? No, there is the ultrasound.
Yeah, and you would do an ultrasound for her. We said you would do an ultrasound. You were also wondering why her fundal height was higher, right? Okay. So you would do an ultrasound to see, let's see what's going on, right?
But not
let's see what's happening.
No, if the age, we didn't know anything.
Yes, exactly.
Right. I didn't give you that information. So remember at the last, when I went over the answers with you, remember I said the last sentence I said was anything else would depend on additional information, right?
Okay. So we have data and we work on.
Right. Now remember, Fred, you had asked me a question about nutrition. I want you to think about what are your main concerns about nutrition as it relates to pregnancy? And I know you're going to tell me, well, that's everything. It's not everything. So think about, it's all about growth, right? So calcium for bones. She needs protein. Carbohydrates are the main fuel of the fetus. But carbohydrates in most diets and most American diets is not a problem, right? Okay. But I want you to think about specific, like those cases that we talked about. If she's lactose intolerant, if she's a vegetarian, how do you make those accommodations? What are you teaching her around constipation, right? Those sorts of things. If she's anemic, what are you teaching as far as your diet? So I want you to, don't look at it as, oh my gosh, I have to learn all of this, but think about what are the main nutrients that she needs: iron, calcium, protein, and what do I need to do? Okay.
Right.
All right. So other questions?
I just have one question, Professor, about the Piscasic sign. So it's uterine asymmetry with soft prominence on the implantation side, right? So is it like, so when the mom is laying down, I mean, as well, you know, when she could kind of see it, like it kind of, you see the.
So just what you read to me is as much as I want you to know about that.
Okay.
Don't overthink it.
But just for me to know, because I want to know if that was something I saw when it. So you're laying down and you could see the little
just a slight, yeah,
okay.
yeah,
okay.
Yeah.
I thought that was abnormal.
But I don't want you to, because I know you guys, you might be tempted to go further. If I didn't give more detail on something or tell you that you needed more, you don't need more detail on it. Okay, at this point. And remember that a lot of this we will dig deeper into as we go forward, but I just want you to have to.
Last clarification. So if I understand all of your lecture, we're gonna be okay?
Yes.
Okay.
Yes.
So lecture based, study lecture based. Kind of. Like
I mean, I don't think that I said anything that, I think there was only one thing, I don't remember what it is, only one thing that I said differently than was in the book. But yeah.
Okay.
It's pretty much the same.
Okay. Thank you.
Okay. And I will post the blueprint as soon as I can. So the discussion board is there. I will see you on Monday. So hopefully, and I scheduled it. I know a lot of you prefer to have exams on Monday morning, but it's the first exam. So I wanted you to at least have an opportunity, if you have any questions, to ask me on Monday before the first exam. And then our next exams will be on, I think are on Mondays. But that's it. Okay. And I will post about the, you're welcome. I will post about the room location. I just want to confirm one more thing before I post that, but I will definitely let you know the room that we'll be in advance. Okay. All right.
I have a question, Professor, but not pertaining to the exam though. Just a curiosity. So, like we say that the fetus has to be adequately oxygenated with the fluid coming in through the whatever. But then, is there such thing as like access of like fluid, like how we have hypervolemic shock? Does that thing apply to the fetus as well? Like,
And yeah, it can. And those are things that we'll talk about when we more in complications. But if the if you're seeing, you're going to see those changes on your strips.
Okay.
You will see that on your strips. Yeah.
With like increased heart rate and all that, right?
And decreases.
Okay.
You'll see more decreases.
And also one other thing, like how let's say the body is not ready for delivery, and I did a question where it said that when the body is not ready for delivery, the uterine walls are even if you have like sexual intercourse and if you're producing oxytocin during the process, and if your body is not ready for delivery, it said that the uterine walls are closed, the receptors for oxytocins are closed. Is that correct?
Right. Yeah. Especially if there's enough progesterone on board. Yes.
Okay. So, and also one more thing, with the fetal heart rate strip, we said that we read the frequency from beginning of the contraction to the next
beginning of the next contraction. Mhm.
right. And you said that it was 2 to 3 minutes on the strip we did, but then when I counted, it was 4 minutes. I don't know if I'm
Was
reading
it 4 minutes? It might have been, you know what, one of them might have been, because one of them was longer.
Mhm.
So yeah, I mean, I was just, you know, quickly looking at them.
Okay.
So yeah.
Okay. Yeah. So also one more thing you said about amniotic fluid, we have to infuse it if there is a variable in the
If there are variable decelerations due to a lack of fluid. But don't worry about that for Tuesday. I just wanted to mention that, but we will, you can, don't worry about that for Tuesday for the exam. We'll talk about that after.
Okay. I was just
Okay.
wondering, how do you infuse it? Like,
Okay.
what oligohydramnions? Okay. Thank you.
It's through the IUPC, but we'll talk about that after the exam.
Okay, perfect. Thank you.
Okay.
That's it. Thank you.
Okay. All right. So if there are any other questions, let me know. Okay. I'll stay on for a few minutes. I think there were a few questions, but the rest of you, I will see on Monday, or I will see you online or something. Okay.
Have a good day.
Okay. Thank you.
Thank you, Professor.
You're very
Professor-
welcome. So this question about genetics, it would be, so I'm not asking you anything about fertility. We'll talk about
Or
infertility
chromosomes or.
later. If I ask you anything about chromosomes or genetics, it's going to be the bare basic minimum stuff that you should know from bio, whatever it is that you guys take, the
Or like
AMP.
how many chromosomes?
Yes, basic, it's
Yeah,
a basic,
okay.
it's
As
basic.
far as the psychosocial part, from your slides, it's very, it's you know, it's not a lot of information. Well, it's good enough information, but the book.
You
really
just need
goes
what
more
I've
in
talked
detail.
about.
Okay.
You
because-
just need what I've talked about.
Okay.
Yeah.
Yeah, because the
Unless
book
you
is a
want
lot.
more. I mean, because I'm always willing. I can always give you more. If you guys feel like you don't have enough, I can give you so much more.
No, because I read the chapter and it's very, you know, it's a lot more. But I like the slides. The slides are good.
Okay. All right.
Bye.
Bye.